In this section, we'll be discussing on one of the most interesting inventions of mankind, that is NPPV, non-invasive positive pressure ventilation. We know that we have two types of NPPV. One is the CPAP, continuous positive airway pressure, and second is the BPAP, bilevel positive airway pressure. Both have very limited indications, all right, but they work excellently well for those limited set of indications where they tend to avoid intubation in those cases where otherwise intubation is going to have its own complications of its own. So it avoids the invasive forms of mechanical ventilation in those patients. That's why it's excellent. At the same time, don't call BPAP as BiPAP because I generally tend to avoid the term because BiPAP really means bilevel positive airway pressure. No, because BiPAP is a company name. The BPAP is a true definition of bilevel positive airway pressure. Fine. So what are the ways that this NPPV is going to work? In the sense, what is the true physiological means how NPPV is beneficial to the patients by working in two different ways. One, by reducing the work of breathing. And second one, it optimizes the VQ matching, which means it improves the VQ matching and optimizes it. In other words, I can tell it prevents VQ mismatching. These are the two ways how NPPV is going to work. So for understanding how they reduce the work of breathing, let us move on and discuss this particular image. This is one of the best images I have come across in pulmonary physiology because it gives so much of information. And since it's a measure of pressure and volume on X and Y axis, you can use the same curve for determining compliance as well. So we all know that when the lungs and chest wall are together, that is a human body, at zero pressure, they will come to a volume referred to as functional residual capacity, right? We have discussed this multitudes of times. They are come to reach a point called a functional residual capacity, right? And this functional residual capacity is the volume, that is what we define as an optimal volume, FRC. And the physiological FRC is what we define as a optimal volume because at this point, the lungs will neither be too much distended nor too much collapsed also, so that it's an ideal volume to expand the lungs, so it will reduce the work of breathing. You can ask me how they can reduce the work of breathing. It's very simple. I told you, you can imagine lungs like a balloon. Both are elastic. And from a fully collapsed portion, it's very difficult to expand the lungs. In fact, the balloon itself. When it is optimally expanded, it's easier to expand from that point. You would have identified yourself when you're blowing a balloon. When it is too much, also it becomes difficult to expand because it reached the capacity of that maximum distension. So after that, you need a lot of work to expand the balloon or even the lungs for that matters. So that is the reason I told you this FRC is the one that's going to provide you the optimal volume, which means it is a little inflated already from the start of inspiration so that it reduces the work of breathing dramatically from there on. So that's what happens. Fine. So one more thing what you can notice is the fact that when you remove the lung and the chest wall separately, which means you take the lungs out and the chest wall separately from a cadaver probably, you can see that lungs, when they are separated out, they tend to collapse. Clear? They tend to collapse and they come to a very, very least amount of volume called as a minimal volume. Don't tell zero volume because it cannot be zero. Nothing, no volume in the universe can be zero, including vacuum. So don't tell zero volume. So it comes to a least volume called a minimal volume. Now, when you are releasing the chest wall from the lungs, so they tend to expand and they try to reach a little higher volume. And what you can notice from the curve is the fact that the lungs, obviously, they are almost always in the tendency to collapse and the chest wall are almost always in the tendency to expand when they are separated, like from each other. When they are placed with each other, when the lungs and the chest wall come closer, like in the living human being, where they are placed together, obviously the collapsing forces of the lung and the expanding forces of the chest wall exactly counterbalance and neutralize at a point, and that's what we have been discussing about this all this while. At the point called a famous FRC, functional residual capacity, which means when you die at FRC, right? When you stop breathing, that is FRC. When you go for apnea, it is FRC. At end expiration, after tidal end expiration, you reach FRC. Clear? So this is the FRC. Very, very important optimal volume for the lungs. Okay. Whenever you increase the collapsibility of the lung, which means if what I'm trying to tell is if you reduce the compliance of the lung, in the sense you're trying to increase the collapsibility of the lung, means you will reach a new destination, new FRC, where the FRC will be much, much, much lower than the original FRC. So now definitely this is going to increase the work of breathing, because the more and more you shorten the lungs from the optimal point, you need a lot of work of breathing to break down the elastic forces. I told you already. So they are going to increase the work of breathing. Similarly, when you reduce the compliance of the chest wall, once again, you are actually reducing the expansive forces of the chest wall. Whether you increase collapsibility or when you reduce the expansibility of the chest wall, because these both are counterbalancing. So when you reduce the expansive force of the chest wall also, they are going to collapse back, and they will, here the collapsive force will become more than the expansive forces. So that once again, you will result in much lower FRC than the physiological range, and you are going to increase the work of breathing to expand the lungs from this point. That is the reason I was clearly telling this FRC is the optimal volume where you can have reduced work of breathing, or in fact I can call it as an optimal work of breathing. That is natural physiological reduced work of breathing. So what are the conditions that can reduce the compliance of the chest wall? A lot of causes are there, but the topmost must be the neuromuscular disease. This is what they will expect in exam. Any neuromuscular disease? Yes, the expanding forces are less here. Then kyphoscoliosis. Then conditions that cause bony problems of the chest wall, like pectus excavatum or pectus carinatum. In general, the pectus excavatum has a more effect compared to that of the carinatum. Then severe morbid obesity. That's the reason in morbid obesity, some patients may go for obesity hypoventilation syndrome called Pickwickian syndrome. Then ascites. The patient is having a scleroderma, thickening of the skin over the chest wall, difficult to expand it. Fibrothorax, fibrosis of the lungs along with the pleura around them, a particular area of the lung. Flail chest, lot of examples we can tell, but the most important will be the first two. Very, very commonly asked in exams. Even pleural diseases also you have to know, like fibrothorax. Alright. So what are the conditions that reduce the compliance of the lungs itself? First condition, almost critical care, always it is ARDS. ARDS is the most important in ICU, that reduce the compliance of the lungs. Apart from that, you can remember ILD, pulmonary fibrosis, because ILD means you can imagine like a pulmonary fibrosis or candidate disorders. So that is also equivalent to ILD only. So these are the two things that you have to know for sure. Very, very, very important. Apart from that, you have a tension pneumothorax, some other causes you can remember. Then pulmonary edema, dynamic hyperinflation. Remember, only dynamic. Clear? Static hyperinflation means high compliance. Dynamic means low compliance. So that we have seen in emphysema itself. So these are the different conditions that causes low compliance of the chest wall and the low compliance of the lungs, which might result in a lower baseline volume, that is FRC, compared to that of the normal physiological volume. So the optimal volume is reduced. Because of that, you will result in higher work of breathing. Fine. So now, how your this BPAP is going to work? By reducing the work of, breathing. Because BPAP produces something called a EPAP. That's called expiratory positive airway pressure. Similarly, that is equivalent to something called a CPAP. In a CPAP machine, that's called a continuous positive airway pressure. To an extent, it's equivalent, not exactly equivalent. To an extent, it is equivalent. Similarly, you have a PEEP. That's called a positive end expiratory pressure in the mechanical ventilator. So only the machines that use is different. EPAP is a terminology used in BPAP machine. CPAP is a terminology that is generally used in a CPAP machine. And this PEEP is generally a term that is used in the mechanical ventilator. Clear? So when you are using an invasive mechanical ventilation like endotracheal intubation, that time you refer to as something called a PEEP. But these three terms are interchangeably used, even though they have the same concept behind them, but they are interchangeably used in different areas. Clear? So whenever you are applying a CPAP or a EPAP or a PEEP, what are you trying to do? You are trying to increase the baseline volume of the lung, a collapsed lung. So as I told you, as you increase the airway pressure, your volume is going to increase, definitely. And the transpulmonary pressure, as you keep increasing, the volume of the lungs are going to increase. You can see the volume of the lungs and the chest wall, or volume of whatever it is, it's going to increase. Now, since the lungs are in more collapsed state, so whenever you increase the airway pressure, there is a lot of chance that they might reach a optimal volume. From there on, to inflate the lungs, it becomes much easier. The lungs become more compliant and it becomes easier to inflate from there on. So that is the idea of giving a PEEP in the first place. So let us discuss about this more when I'm going to talk about the VQ matching also, right? So let us wait. So I'm going to put another diagram. So after this one, so this is just to understand some basic concepts. And this image also tells you an important point, but that is not relevant to the current discussion, but I want to tell you that I told you in the compliance chapter itself, whenever a curve in a pressure volume curve, a curve is closer to the x-axis means that is less compliant, and the curve that is close to the y-axis means that is more compliant. So here you can see the chest wall alone and the lungs alone are relatively more closer to the y-axis compared to the lungs and the chest wall together, which is relatively more closer to the x-axis, which means the chest wall alone is very compliant, the lungs alone is again compliant, but the chest wall and the lungs alone is actually less compliant than the other two structures keeping alone. So this is what the curve tells, very, very important point to know. Fine, so this is not relevant now, but just with the curve, it's a very important interpretation as well. Now let us go and discuss another curve, because I do like curves because they tell you a lot of information. So second curve I'm going to talk about is the compliance curve of a normal lung and the compliance curve of a probably ARDS lung, which is going to show a very low compliance. And let us see the pulmonary vascular resistance also. Let me draw a different curve that tells you the pulmonary vascular resistance. So what's going to happen is, first I will draw the normal lung like this. Clear? So I'm going to draw the normal lung. So what you are seeing here is, this point in the beginning, it's very difficult to inflate the lungs. Clear? So this is actually a collapsed lung. This is a collapsed portion or a collapsed lung when you take outside. And you can see this is a pressure volume relationship, right? So this is a transpulmonary pressure on x-axis and the volume on the y-axis. You can see in this area, the increase in the pressure is not at all translating to increase in the volume. The volume increase is very, very less. So that's why I'm telling you this area is having very low compliance. That is due to two reasons. The collapsed lung will have very high level of surface tension. At the same time, they're going to have very high elastic forces. Both of them have to be broken with high energy. That's why at this point, you will have a very high work of breathing. Similarly, when you have hyperinflated the lungs, which means when the lungs have reached the maximal volume. So again, you can see in this point, increase in the transpulmonary pressure is not going to translate to increase in the volume at all. A minimal change in the volume will happen. So that is because this area, the lungs are hyperinflated alveoli. So once again, because the compliance is very low in this area, and again I can write the compliance is very low because of too much distension, you are going to have increased work of breathing in this area. It is very difficult to increase beyond this point. That's why both hyperinflated lungs as well as collapsed lung is going to show a very high work of breathing. That is because of low compliance. We have discussed that already. But there is a point, you can see, where the lungs are relatively easier to expand. That is the steep part of the curve, the sigmoid curve, where a unit change in the pressure is associated with a good change in the volume as well. So this area is actually showing a good compliance, and FRC must be somewhere here only physiologically. For example, if you take the zero airway pressure, for that matters, if you take this the zero airway pressure, you can see that this will be the FRC at this point. So which means your breathing will happen in this range, which means your lungs will expand and deflate, expand and deflate, inflate and deflate over this point where the compliance is very good for the lungs. So this is FRC. So that's how FRC helps. This is a vague curve. This is just to understand. Just try to understand what I'm trying to do. So that's how FRC will help you in making the lungs to be in the compliant portion of the curve so that it becomes easier for you to inflate and deflate the lungs. Even though there is hysteresis, yes, I don't disagree with that. But right now you can understand in a very simple way. I don't want to complicate by telling the hysteresis curve and all. That we have discussed in the compliance itself. Fine. So this is FRC. So in this range, because the compliance is high, your work of breathing will be pretty much low. So once again, we can see the pulmonary vascular resistance also. We can put the volume on y-axis and the pulmonary vascular resistance on x-axis. Now, if you take a collapsed lung, for example, if the volume of the lungs is very, very low, this is a collapsed lung, right? At the collapsed portion, you will see a very high pulmonary vascular resistance, right? You will have a high pulmonary vascular resistance. At the same time, in a hyperinflated lung, so if the volume is very, very high, the lungs are hyperinflated. And you can see once again, the pulmonary vascular resistance will be very, very high. The reason is because in a collapsed lung, there will be a VQ mismatch, obviously, because collapsed alveoli means there won't be sufficient oxygenation and ventilation in that alveoli, so that they'll go for hypoxic pulmonary vasoconstriction and they will have high pulmonary vascular resistance in that area. Similarly, in hyperinflated lungs, due to increased intraalveolar pressure, they will themselves compress on the blood vessels, and they will prevent the movement of the blood, resulting in increased pulmonary vascular resistance. This is what we saw creating a dead space in waveform capnography. Hope you understand. Increased intraalveolar pressure will actually reduce the perfusion and creates a lot of dead space in the alveoli. Go and watch the waveform capnography section. So what will be the FRC? So whenever you have an optimal volume, not very less, not very high, an optimal volume, this is FRC. You can see the resistance is very, very low, which means you can maintain a good VQ mismatch. The pulmonary vascular resistance is very less. So when you combine all the curves, all the 3 points, you're going to result in a formation of a parabola, right? So you will result in a formation of a parabola like this. So this is what you will be getting, which means this is not like a linear relationship. This is like optimal volume. That's what it matters. At optimal volume only, you are having a good VQ matching, good ventilation, perfusion matching. As the volume increases beyond FRC or the volume decreases below the FRC, again it is going to be a little bit bad only, because you are going to increase the pulmonary vascular resistance and you are going to worsen the VQ mismatching. Now let us put all these things into a single graph. Whatever you have learned till now, let us integrate and see from a common perspective. Let me put a mega graph here, which will integrate all the 3 curves which I have shown you. The complaint curve and the pulmonary vascular resistance curve also. So I can write the transpulmonary pressure here, and later on I will be putting the pulmonary vascular resistance in the x-axis as well. So initially let us consider the transpulmonary pressure. Y-axis is the volume for both the curves I have mentioned in the previous image. So now let us put the normal lung, how it's going to behave. So this is the curve of the normal lung, right? So we have seen that. And let me draw a lung with a very poor compliance. For example, an ARDS lung. So how it's going to behave. So this is the curve of a ARDS lung. So why I am putting a lot of dotted lines in the bottom is because there will be a lot of collapsed segments in the alveoli, in the lung, because of the alveolar filling process in ARDS. Lot of segments of the lung will be collapsed completely. So that is why the baseline volume itself is very low and takes a lot of pressure to open up this alveoli. And again they will open up and they will enter the steep portion of the curve, that is the complaint portion of the curve, and again they will come here and they will end. So this is a lung with a low complaints, for example ARDS. And this black dotted line is a normal lung with a normal complaints. Don't tell high complaints, just write a normal complaints. Okay. So what is the basic difference? So if you see at a pressure of 0, at a transpulmonary pressure of 0 centimeters of water, what's happening here? So you can see the fact that the normal lung will be at FRC, right? So the normal lung will be at FRC. This is an optimal volume. This is a normal physiological FRC, functional residual capacity, at 0 pressure, 0 centimeters of water. But if you take the ARDS lung for that matters, or a poorly compliant lung for that matters, you can see a lot of alveoli will be collapsed at that point, and the FRC itself is very much lower. The FRC is too much low in this particular patient with a poorly compliant lung. And second point that you can notice, a normal lung at FRC will be in the steep portion of the curve, which means they are in the good compliance portion of the curve. That is why you are having reduced work of breathing when you breathe normally through a normal lung. But an ARDS lung is not going to behave like that. The ARDS lung is actually located in the flat portion of the curve, isn't it? The baseline FRC of an ARDS lung is located in the flat portion of the compliance curve, which means they are going to have a very poor compliance at baseline, which will be translated into high work of breathing in this particular patient. So that is why we give a positive pressure called PEEP. Remember, PEEP is similar to that of CPAP, not exactly. And again, it is similar to that of EPAP, expiratory positive airway pressure, in case of a BPAP, right? So PEEP, CPAP, BPAP, you can right now imagine like a similar terminology, but all are little bit different in small ways. That's it. So now let us increase the pressure a little bit and make it plus 5 centimeters of water, right? I'm giving a continuous positive airway pressure or a PEEP, positive end expiratory pressure, and increase the expiratory pressure and keep it constant at plus 5 centimeters of water. Which means what I'm trying to do is, in this graph, if I increase, I'm not talking about the normal lung here, an abnormal low compliant lung like ARDS lung, now the new volume is going to be somewhere here. Clear? So which means what I'm trying to do here is, if you equate that, I'm trying to increase the FRC, right? And trying to mimic a more physiological FRC level. Now let us see this portion. Now you are entering the compliant part of the curve, right? You are not in the poorly compliant region. Just by putting a PEEP, by opening up more and more alveoli and keeping them distended, you are entering the more compliant part of the curve, which means now it will be a little bit easier to expand compared to the completely collapsed portion. It becomes difficult to expand. So I can write now the compliance will be definitely higher in this area, at least to an extent, at least, even though the graph might over predict what you are trying to think, but still it explains you what you want to know. So increase compliance, at the same time it will reduce the work of breathing. So that is how your PEEP or a continuous positive airway pressure or any positive pressure ventilation, this is the mechanism how they reduce the work of breathing, by keeping the alveoli in the open portion or in the optimally distended portion. You should not tell distended portion, optimally distended portion, so that your expansion becomes a little bit easier if you have a good neuromuscular power. Again, disclaimer. If you have a poor neuromuscular power, just opening up the alveoli does not work, because the muscles and chest wall has to expand to further expand this alveoli during inspiration. If you have a neuromuscular weakness, that is a different ball game. I'll come back to that later on. Clear? But a conscious, normal muscle power patients, definitely this opening up of alveoli is very, very beneficial for expanding their alveoli in a much better way. Fine. So understood. So let us now understand about the VQ matching also, how this PEEP or increasing the positive pressure will help in the VQ matching in a patient who is having a low compliance. So now let us put a pulmonary vascular resistance curve in the same image, because both are similar. So let us equate that. So difficult to draw, but still I'll try to do justice to this. Okay. So let me draw, a conceptual diagram. This is not an exact one, but a very conceptual one. So what you are seeing here is, at an optimal FRC, definitely at an optimal FRC, there is very, very low pulmonary vascular resistance. So pulmonary vascular resistance, now I'm equating in the x-axis. So at optimal FRC, my pulmonary vascular resistance is extremely low, right? Fine. But what happens in a patient who's having a very low volume, like at this FRC, in a patient with the ARDS or a patient who's having a poorly compliant lung, if you see the pulmonary vascular resistance, if you equate where it goes, let me predict. So it goes. Wow. Here the pulmonary vascular resistance is here. So which means a patient who's having a baseline FRC which is very much reduced, like in a patient who's having ARDS, the pulmonary vascular resistance is very, very high, which means there is going to be severe VQ mismatching in this area. Severe VQ mismatching. And that is one reason. Obviously, the exact VQ mismatch in ARDS lung, it's very difficult to predict. That is why we generally call this as shunt formation. Here, the ventilation will be very, very poor ventilation, because it's a collapsed lung. At the same time, the perfusion also will be very poor, resulting in a very severe hypoxemia and a shunt formation also. Clear? So whatever perfusion that is going to that particular alveoli will, go without getting oxygenating at all, completely will move to the other part of the circulation, which means without getting oxygenated. That's what we call the shunt formation. So this is what is going to happen here. Severe VQ mismatch. What you're trying to do by putting a PEEP. So now just by putting a PEEP in these patients, you are improving the VQ matching. Clear? So how you are doing that? So now you know that the new volume of the lung after putting a PEEP of 5 centimeters of water is somewhere here. So you can see. So I can put in yellow color here. So you can see now by putting a PEEP, now the new volume is that. So at that new volume, if you track, so this is the new volume. At this new volume, if you track and see the pulmonary vascular resistance, it's somewhere here, right? So I can draw the new pulmonary vascular resistance here. So which means you can see the pulmonary vascular resistance is very much reduced after putting a PEEP. So which means your ventilation, which means your FRC, the baseline volume is also increasing. At the same time, your pulmonary vascular resistance is also decreasing, which means you are going to improve the ventilation also. You are improving the perfusion also, which is resulting in a better VQ matching in this patient. But again, remember, too much PEEP is also dangerous. I mean, your PEEP depends on how much alveoli are collapsed and how less your baseline FRC is and baseline lung volume is. For example, if you put the same amount of PEEP in a normal lung, which is not necessary, it will expand better. But the problem is again, your pulmonary vascular resistance will be high and your VQ matching will not be proper and VQ mismatch will result. So it all depends on which area and which purpose you are going to put this PEEP and which scenario you are going to use and how much PEEP to put again depends on the compliance of the lung. The lower the compliance, you can increase the PEEP and try to open up the alveoli better and keep in the optimal position. If the compliance of the lung is already better, putting more PEEP will distance the alveoli more and more, resulting in again VQ mismatching and hypoxemia only, and you might not have a proper perfusion to that particular alveoli, resulting in dead space formation. So you have to be very clear about that. So PEEP is not always good. Clear? It is good only when you have a poorly compliant lung or a alveolar filling process and in an example like ARDS. Fine. So this is the idea. So that is how the PEEP or a CPAP or a EPAP in a BiPAP works, by reducing the work of breathing because you are putting the lungs in the more compliant portion of the curve. At the same time, you are improving the perfusion. I mean, you are reducing the pulmonary vascular resistance and improving the VQ matching also, thereby reducing the hypoxemia also. These are two quintessential principles that how the NPPV works, or any positive pressure ventilation works for that matter. But remember, when a patient is having a neuromuscular weakness, whenever a patient is having a neuromuscular weakness, just putting a PEEP or a EPAP in a BPAP is alone not enough. Why? Because, for example, if you are opening up the alveoli, from this point to expand further, you need a good muscle power. If you don't have a muscle power, you will be just expanding from the collapsed portion, which will, yes, reduce the work of breathing to a great extent, but still, these patients, if they are having severe neuromuscular weakness, they cannot expand the alveoli better. They will still struggle to expand this alveoli. So that is the reason why we are giving a new inspiratory force also. When the patient is inspiring, that time you give an inspiratory pressure also, so that you are trying to expand the lungs from inside and by providing a positive force, so that now the alveoli will expand better. So giving a baseline positive pressure is to open up the collapsed alveoli, and giving a inspiratory positive pressure is to expand the alveoli during inspiration, especially when you are having a severe neuromuscular weakness. That is why whenever in ICU a patient is paralyzed, you should give a positive inspiratory pressure also, because these patients who are paralyzed with neuromuscular blocker will not have any inspiratory force at all. You have to inflate the alveoli by giving a positive pressure. Just opening up the alveoli by giving an expiratory positive pressure is not enough. Just giving a PEEP is not enough. In a spontaneously breathing patient, giving just a PEEP is enough most of the times. But in a patient who is having a severe neuromuscular weakness and not spontaneously breathing, you have to give an inspiratory pressure to open up the alveoli mechanically. That's all. Now let us see the differences between a normal breathing versus a patient who is breathing in a CPAP circuit and a patient who is breathing in a BPAP circuit. Fine. So this normal breathing, we have already discussed enough already, but let us just put a graph, a baseline graph, which will be helpful in understanding, right? So I'm going to put the same graph for CPAP and EPAP, even though the graph might look different, but the applications are the same. So how does a normal patient breathes out? So it's very simple. So this will be the curve. So normal patient breathes around the baseline of 0 centimeters of water. That is nothing but the atmospheric pressure. So during inspiration, you know the pressure will drop, and during expiration, the pressure will rise. But at the end of inspiration, at the end of expiration, the pressure will reach the atmospheric pressure. That's the idea of normal mechanics of breathing. I've discussed extensively in the basics of pulmonary medicine chapter. So inspiration, you reach a negative value, and expiration, you reach a positive value. Clear? That's the idea. So what you are trying to do in a CPAP? In a CPAP is a little different. What you are trying to do is I'm giving a continuous positive airway pressure. A continuous positive airway pressure, that is what we refer to as a CPAP, which means you can understand that I am just setting the baseline from 0 to a much positive value. That's all. So just I am increasing the baseline. So let us assume in this case it is plus 5 centimeters of water. It's not 0, it's plus 5. I'm just increasing the baseline. Now what will happen is, now the patient is spontaneously breathing here. Obviously do not use CPAP in a patient who is not spontaneously breathing. It's of no use. I'll tell you why. So spontaneously breathing patient, and the patient will be breathing out something like this. Simple. Which means what I'm trying to tell is the patient is breathing spontaneously, yes, just he will be breathing around the CPAP pressure. That's all. Here the baseline itself is gone to a much more positive value. That's it. The idea of this is, even during inspiration or even during expiration, you don't reach a negative value at all. So inspiration, you're not giving a positive pressure, but still you are maintaining the pressure in the system in the positive value. During expiration also, you're maintaining the pressure in the positive value only. So this is what happens in a CPAP circuit. So what is the advantages of giving a CPAP circuit? Because you are maintaining the baseline lung volume. Again, you can see the end inspiratory or end expiratory pressure will be at the positive range only, which means you are increasing the baseline pressure in the respiratory system, which means you will be increasing the baseline volume. Your FRC will increase because the baseline pressure is high. That's why end expiratory pressure is high. Baseline pressure is high, so the baseline volume will be high. That's why your FRC will increase. That will definitely open up a lot of alveoli, open up a lot of collapsed alveoli in the lung. Clear? There is no doubt about that. They are going to open up the collapsed alveoli. Or they can open up the airways also if they are collapsed. But whether they can ventilate the patient or not, no, they can't ventilate the patient. Why? Because this inspiratory and expiratory effort of the patient, whatever effort the patient is giving, this inspiratory and expiratory effort of the patient is patient dependent. So how can you understand that? CPAP, by maintaining a higher baseline pressure, can try to open up the alveoli, but from this portion, this is the baseline portion of the alveoli now, from this position, how much ever it opens up and comes back to the original portion depends on the patient. The patient breathes with a very less power, only this much will open. But the baseline, will maintain in the opened up state only. But the ventilation may not be perfect, because how much alveoli opens up and comes back to the original portion is what we call ventilation. Opening up is different from ventilation. Opening up means just you open up and keep it in the baseline. That's all. Hereafter, how much the patient breathes in and breathes out and comes back to the baseline depends on the patient itself in CPAP. Which means the patient's power determines how much ventilation you are doing. So here the CPAP cannot provide ventilation. It can open up the alveoli, but ventilation is patient dependent. That is why in a patient who is having a alveolar hypoventilation, that is a type 2 respiratory failure, you cannot use a CPAP. Do not use a CPAP alone. CPAP alone or a PEEP alone will not be helpful. It's not going to be of any help at all. Okay. Now, what is a BPAP? So BPAP provides some unique advantages, like it's going to have two level pressures. One is the EPAP pressure, which is similar to that of the CPAP, but with a slight difference. But they tend to maintain something called the EPAP pressure as well, IPAP pressure as well. This is called inspiratory positive airway pressure. So what happens? Let us assume a patient who is spontaneously breathing. Alright, patient who is spontaneously breathing and breathing normally. Now, let us assume this is the expiratory phase of the patient. Again, they will be maintaining a constant expiratory pressure. And in BPAP, one important thing to know is the pressure of the system will not go below the EPAP pressure. But in CPAP, you can see the pressure of the system is going below and above the CPAP pressure. So which means the most important thing is it's going below the CPAP pressure. Yes. But in a BPAP, your pressure will never go below the EPAP pressure. It will be maintained at the EPAP pressure. That's the least pressure that the system can reach, except during inspiratory efforts. Let us see. So now let us see the patient. Think that patient is trying to breathe in, inhale. Obviously, we will try to lower the pressure. You will try to put a negative pressure because the diaphragm tends to move down, and the patient, that's how the patient's going to breathe. This will be detected immediately by the sensor in the BPAP. So it's going to give a positive pressure and mechanically distend the alveoli by giving a set IPAP pressure. Simple. Similarly, again, the patient will try to breathe spontaneously, but this will be sensed by the BPAP machine, and they'll give a mechanical force that will open up the alveoli. In the sense, it should not tell open up, it will distend the alveoli from the baseline position. Already it's opening up. EPAP is one thing that's going to open up the alveoli, that is different, and keep it in the baseline opened up position. But after this, the distension also, how much the alveoli can distend also, you can determine by setting the IPAP pressure. Clear? So that's why I'm trying to tell, having a BPAP is very advantageous because this EPAP feature in a BPAP is going to increase the baseline volume, right? You're going to increase the baseline volume, which means it can open up the alveoli and the airways. It can open up the alveoli and it can open up the airways also. Fine. This IPAP setting in a BPAP is definitely going to ventilate the patient also. It can be used in ventilation also. This is the major difference between a CPAP and a BPAP. BPAP can ventilate, which means you can determine how much the alveoli should distend during inspiration by giving a mechanical positive pressure during inspiration, and mechanically you are opening up the distending the alveoli. Fine. Remember, so this difference between the IPAP and the EPAP is the one that's going to determine the ventilation, which means that is the one that is going to determine the tidal volume of the patient also. Clear? So how can I write in an equation form? There is something called an equation of motion. This you should never forget whenever you think about the ventilator, positive pressure ventilation. So now what's happening in an equation of motion? That is peak inspiratory pressure. That's the inspiratory positive pressure that is reaching the peak is equal to flow times the resistance plus tidal volume by compliance. That's the idea. So which means you can see that whenever I set a peak inspiratory pressure, that is going to set the tidal volume also. If I increase the peak inspiratory pressure, my tidal volume will increase. If I decrease the peak inspiratory pressure, my tidal volume is going to decrease. Obviously, it depends on compliance, resistance, a lot of other features also. But one important relationship is its direct relationship with tidal volume, the peak inspiratory pressure. So that is why this IPAP, how much ever you set, that much you can distend the alveoli and you can increase the tidal volume. Fine. So this is the basic idea of giving a bi-level positive airway pressure, which can be helpful to ventilate the patient, which means I can use this BiPAP or a BPAP in a treatment for alveolar hypoventilation. Alveolar hypoventilation, right? Alveolar hypoventilation means you're having two types, isn't it? This is a type 2 respiratory failure, which means you have two types of alveolar hypoventilation. One is patients who won't breathe. Second is patients who can't breathe. Okay, can't breathe patients, all right, it's very, very simple to understand. They'll be having a low tidal volume to achieve a normal tidal volume, because these patients should have a normal tidal volume now. This is because of neuromuscular weakness. Can't breathe is due to neuromuscular weakness. Clear? So to achieve this normal tidal volume in a patient with neuromuscular weakness, I'm going to set a IPAP plus or minus a EPAP. Here EPAP, may or may not be needed, because in a true type 2 respiratory failure and neuromuscular weakness, I don't need a EPAP at all, because the main thing is alveoli is not getting distended here. That's the main problem. So just giving IPAP is more than enough. Even if you want EPAP, you can set at low range like plus 5 centimeters of water. It's not going to harm your patient at all. Fine. So this is understood. Fine. But these patients who won't breathe, the main problem is the low respiratory rate. We have discussed in detail in the respiratory failure section. They are going to have a low respiratory rate. But how you are going to treat this patient? Because we have discussed only spontaneously breathing patient, we have not discussed about a patient who's having apneic episodes. Apnea. During apneic times, how is going to help? Let us see. Now, you are going to use another feature in the BPAP called as a backup respiratory rate. You have another feature in the BPAP called backup respiratory rate. So, for example, you are setting a respiratory rate of 12 per minute, which means the machine knows that every 5 seconds, the patient should develop an inspiratory effort. That's what you mean by breathing rate of 12 per minute. 5 seconds once, you get a breathing. Suppose if the patient doesn't breathe for more than 5 seconds, 5 seconds have elapsed and the patient has not breathed, means this backup respiratory rate in the BPAP will kick on and they will give a breathing by themselves and they will give an artificial ventilation to the lungs. And here you can see the patient is not giving any inspiratory efforts at all. Still the BPAP machine will recognize, because it has its own backup respiratory rate. The patient doesn't breathe. Within that time, they are going to distend the alveoli mechanically and help in the breathing of the patient. So that is why this patient who's having a bradypnea or a lower respiratory rate, still, which means if the patient is going for apneic episodes, I can use this IPAP plus or minus EPAP. Again, EPAP is not very mandatory here, but IPAP is the most important because IPAP is the one that helps you ventilate. Very, very important. Plus, definitely I have to use backup respiratory rate. If I am scared that the patient might not breathe in between and he might stop breathing because of apnea, always use a backup respiratory rate. But here, backup respiratory rate is again optional only. Here, definitely the patient will not forget to breathe in a pure neuromuscular weakness. It's only the weakness of the muscle that is having low tidal volume. That's the problem here. So you don't need to usually give a backup respiratory rate, but these are optional things. But whenever you set a BPAP, it's traditional to set an IPAP and EPAP with a backup respiratory rate, which helps you in treating the low tidal volume, which helps you in treating the low respiratory rate also. In the sense, it will help you in treating the alveolar hypoventilation. At the same time, it can open up the alveoli as well. So CPAP and BPAP can open up the alveoli, increase the baseline volume. Yes, all these things they can do. And only BPAP can ventilate the patient. That is, in type 2 respiratory failure, you can use only BPAP only. But please be very careful. In a patient who is having a low GCS or altered mental status, we generally don't use this CPAP and BPAP machines. We go for invasive mechanical ventilation. That you have to be very careful again. Because in a only very conscious patient, you can use this mask ventilation, non-invasive ventilation. Fine. I think now you would have understood the difference between a CPAP versus a BPAP, right? So it's beautiful. And let us see the video. So this is a ventilator curve where you can see two pressures are there. One is the EPAP pressure and second is the BPAP pressure. IPAP pressure. So it's set at 4 and 8 here in this example. And the patient gives an inspiratory effort. Whenever the patient gives inspiratory effort, the machine picks up the positive inspiratory pressure and reaches the set IPAP pressure. You can see the same thing is seen here. Whenever the inspiratory effort is there, you are getting a positive inspiration. This is a CPAP typically. You can see there is a constant pressure that is maintained and the patient is breathing in and out of the constant pressure. Clear? So this will be the inspiration and that will be the expiration. So in a CPAP, it's very clear that the pressure during inspiration can reach below the CPAP pressure. But in a BPAP, it's very sure that the pressure of the system will never go below the EPAP pressure, except during inspiratory efforts. Apart from that, the pressure will never go below the EPAP pressure at all. So this is a curve, that ventilator graphics that show the BPAP and the EPAP. Clear? Let us see for one more time. And what are the settings here? You can see the settings here. The backup rate is 12 here, EPAP is 4, IPAP is 8. And there is something called a patient leak you can see here. Clear? So 6 liters, 4 liters, that is also going on the top left corner. Patient leak is there. That is also important to know because BiPAPs can, these non-invasive ventilation machines can often leak their pressures out because of the poor mask fit. Here also I'm trying to show, here only the CPAP is set. There is no backup respiratory at all. That is very, very important to note. And here also there is something called a patient leak that you are noting on the top left corner. And I played this video for 2 times just to make you understand better between the settings of BPAP and CPAP. So you yourself have seen that CPAP doesn't have any backup respiratory rate setting. So that's why you should never use CPAP in patients with alveolar hypoventilation and apnea. So this is a graph that beautifully shows the work of breathing. Clear? So how you are going to reduce the work of breathing? Just by giving a CPAP, which means giving a positive pressure, will definitely distend the alveoli, and from a collapsed portion, it's going to set a higher baseline volume. So definitely you are having a low work of breathing. Just that is by increasing the compliance of the lung. Fine. But adding a pressure support, that is giving a positive inspiratory pressure like 20, which means this is an IPAP. Here this 10 is a EPAP pressure. Giving an EPAP and IPAP is further going to reduce the work of breathing because it's not due to, because giving an EPAP is not due to opening up the alveoli or increasing the compliance. Here you are giving the IPAP that is to just distend the alveoli. You are increasing the alveolar distension mechanically, which means the patient's force that is needed to distend the alveoli is pretty less. And like the usual ideal BPAP settings, if they ask you, I will tell you have to set the EPAP to 5 to 10 centimeters of water. Beyond this, you don't have much benefit. Generally, my setting is generally 5, 8 or 10. So this is what I set usually. In an IPAP, the usual setting will be 15 to 20 centimeters of water. Again, going beyond 20 is not useful. It has been proven by many trials. So ideal setting will be either a 25 or probably a 20-10. If you want to open up the alveoli more, you can increase the EPAP pressure. But ideal setting will be this. So if you think that you don't want this much of IPAP, you need little IPAP, so you can set at 15.5 or 15.8. So these are the usual settings I prefer generally. So this is very good settings. You can prefer this one, 25 and 20-10, very good. Clear. So this will show you the patient comfort in a BPAP. So remember one thing, the work of breathing may not translate to the patient comfort. So the best decrease in the work of breathing is at 25 and 20-10, maybe 25. That's the best setting you can achieve. So that will reduce the work of breathing drastically, but that may not translate to the patient comfort and patient discomfort. So this is the increasing discomfort in the y-axis, you can see, and this is the average discomfort, clear, in patient population. These are the average discomfort in the patient population. These are two different studies that are taken, where we know that 20 plus 5 is the best setting, where actually the discomfort is little bit higher to the patient. But work of breathing is something different, that will definitely decrease. So, but if the setting is 15 and 0 and 15 and 5, the patient has the best comfort. In this study also you can see the same, the 20 plus 5 has a relatively higher discomfort compared to 15.5 and 15.0, which is having relatively lower discomfort. Which means, what I am trying to tell is the patient discomfort will not be proportional to the work of breathing. Our patient comfort will not be translated as work of breathing. Clear? So something different. So patient may feel uncomfortable at 25, but the work of breathing will reduce drastically. So don't think like work of breathing is equal to the patient comfort here. That's what this graph is going to tell you. Now let us see the advantages of using a NPPV or endotracheal intubation. Definitely the first one is it avoids endotracheal intubation and invasive procedures like tracheostomy and all, because these procedures are intrinsically traumatic. So they can reduce the traumatic procedures on the patient. Clear? So number 2, there is no need of sedation for the patients. Clear? Even though small sedation we use at times, but there is no need of heavy sedation. Like when you are using an endotracheal intubation, definitely patient will not tolerate, at least in the initial phases. You need heavy sedation. Here you don't need it. Number 3, the patients can communicate with the doctor, with the attenders, because patient is awake. Very big advantage. Number 4, patient can have intermittent drinking and eating. Suppose if you have the clinical scenario where patient can be taken off from the NIV mask for some time, yes, you can during that time, and you can remove the NIV mask and give water and food for the patient. Intermittent drinking and feeding of the patient is possible, whereas it is not possible in a patient who is having endotracheal intubation. And finally, they are having low risk of aspiration. Remember, you have to take it with a pinch of salt again. Endotracheal intubation, after putting the tube, the risk of aspiration is definitely less. But during the intubation procedure, definitely there is a risk of aspiration. You yourself know that, because you are paralyzing the patient, giving a bagging and gastric insufflation, so many problems are there till you intubate. Clear? So here, surely there is reduced risk of aspiration compared to intubation. Okay. So what are the complications? Complications of NIV, NPPV or NIV. Number 1 complication is the air leak. Usually the pressure leak will be there. That is, you have the modern machines that can compensate for the pressure leaks. That's why I told you in that video where I showed you that there is a top left corner, you see something called a pressure leak, which was 3 liters, 5 liters per minute. It's actually okay. The pressure leak invariably happens, even though the mask what you use is made of silicone. The area that comes into contact with the skin is made of silicone, which means it is more flexible, so it can exactly fit the shape of the skin. Still, there will be some air leak and gas leak will be there. Air leak and gas leak is equal to the pressure drop. Here you are trying to maintain the positive pressure, so you don't want that pressure drop to be too much. But modern ventilators can compensate for this pressure drop and air leak by giving extra gas flow during the times of pressure leak, and they can detect that how much leak is happening. Appropriately, they can produce that extra gas flow and maintain the pressure. So we use Philips V6 in our hospital, where it actually compensates for up to 50 liters per minute leak. Hamilton ventilators and all can compensate up to, modern generation can compensate up to 85 liters per minute also. And again, it has a set value. Till that only they can compensate. But it's better to avoid the air leaks beyond 10 liters per minute. That's what my opinion is. You have to create a tighter fitting mask. Maybe it's because of the ill-fitting mask that you are getting this air leak. So make a mask a little bit more tight fit so that you don't have any leakage of pressure from the respiratory circuit. Second, skin irritation and abrasion. This is especially common in the nasal bridge. When you are using an oronasal mask, this is a very commonest type of mask we use, oronasal mask. It compresses on the nasal bridge. This is a very delicate area. So when it keeps compressing with a tight fit, that might result in an abrasion over this place. I'll show you the image. It's very, very common. So these patients are good candidates for using a full face mask, or probably they can use a nasal mask alone. So that is also available. Next, patients may become claustrophobic, especially when you're using a oronasal mask or a full face mask. It will look like patient is living inside a closed environment. So patients who are already claustrophobic may get worse. They can go for nasal congestion, sinus and ear pain. That is due to small amount of barotrauma created by the positive pressure given by these machines. They can go for mucosal dryness, or they can go for mucus plug formation. These things are again due to unhumidified air. So try to humidify the air better in these scenarios. And they can also go for pulmonary barotrauma. Quite rare to get a pulmonary barotrauma, but possible, quite possible if the patient is having very, deep inspiration. So spontaneous inspirations, if they are producing high effort, so then probably this could happen. And they can slightly reduce the BP, blood pressure. That is because you are increasing the intraalveolar pressure by giving a positive pressure. Intraalveolar pressure, because you are increasing the intraalveolar pressure by increasing the baseline volume itself, by increasing the alveolar distension by giving IPAP. So definitely there will be some compression on the blood vessels so that they will reduce the perfusion a little bit. Again, you have to take with a pinch of salt. In a collapsed lung, this increased volume may optimize the VQ matching. But if you do more, there is a lot of chance that your BP might drop. See, remember, when you cannot have a molecular level eyes to see what is happening inside. There are certain areas of alveoli that are collapsed. Yes, you are trying to optimize VQ matching in those areas, but there are certain alveoli which are normal also in a pathologically affected patient. So those alveoli, if they hyperexpand by giving a positive pressure, they will compress on their vessels and they will prevent the flow of the blood from left to the right to the left side. So thereby reducing the preload on the left side, resulting in reduced BP. So that is the reason one of the important relative contraindications for NIV is your hemodynamic instability. We don't use. It's a relative contraindication. We go for intubation in the first place. Clear? So these are the complications. Next, we'll move on to the indications and contraindications of non-invasive positive pressure ventilation. What are the indications? There are two indications which is been proven to be very, very good for NPPV. Clear? So first is acute indication. We'll go for the chronic indication. Acute, two indications. The best, time-tested, proven by multiple trials time and again. First indication is acute cardiogenic pulmonary edema. Cardiogenic pulmonary edema, where you can use CPAP or you can use a BPAP also, even though the evidence is more in favorable for CPAP because there are a lot of studies done for CPAP. BPAP doesn't have that much studies that favor use in cardiogenic pulmonary edema, but you can use logically. But CPAP is preferred because of the amount of information we have about CPAP on acute cardiogenic pulmonary edema. That's all. It's not that you cannot use BPAP. But what group of patients you have to select, even if it's a cardiogenic pulmonary edema? Number one, they should not be having any cardiogenic shock. Second, they should be non-ischemic, which means there is some studies telling that one of the complications of CPAP and BPAP is MI. Some studies. So in MI related cardiogenic edema, so better to avoid because it produces MI in certain trials. So in MI, better to avoid. That's what they're trying. Non-ischemic, non-shock related cardiogenic pulmonary edema, definitely yes. Multiple. and loads of evidences are there. Number 2, acute exacerbation of COPD. If they are having hypercapnic respiratory failure, that is hypercapnic type 2 respiratory failure, definitely you can use. And here, the only thing that has evidence is BPAP. Obviously, yes, because if it's hypercapnic respiratory failure, that is due to poor ventilation. Poor ventilation means you have to treat with BPAP only. Indications, if you have a PaCO2 of more than 45 plus a pH of less than 7.3 to 7.35. Clear? So whatever, doesn't matter. So this is the usual indication for a BPAP in a acute exacerbation of COPD. These two are having the best evidences right now to support the use of NPPV. At the same time, they are having some insufficient evidences. At the same time, probable potential benefit is there in certain patients. Potential benefit. What are the conditions which show potential benefit? Number 1, if the patient is having hypoxemic type 1 respiratory failure, hypoxemic type 1 respiratory failure plus immunosuppression like febrile neutropenia, or the patient is having sepsis with ARDS. I mean, before going for ARDS, patient is having severe sepsis because of immunosuppression like AIDS or febrile neutropenia. So definitely you can use NIV to prevent progression to ARDS and probably to prevent intubation. So good in this potential benefit. And second, post-extubation. Post-extubation, obviously you have to make a transition from invasive endotracheal tube to a spontaneous breathing, maybe with a mask oxygen. So this NIV can act as a bridge between extubation and transitioning to a spontaneous breathing. I mean, in the sense like spontaneous mask oxygen. So this NIV is very, very useful in this scenario also. But potential benefit, not completely proven, but potential. And they're having some insufficient evidence also. Insufficient evidence for certain other conditions where you can use. One is pneumonia, ARDS, and acute asthma. So they are having insufficient evidence here. You can use, but we don't have that much trial results to back up the data. So the best indications comes in the form of first two, that is acute cardiogenic pulmonary edema, which is not having shock and non-ischemic. Second is acute exacerbation of COPD causing type 2 respiratory failure. Best evidences we have. Then, in chronic conditions, where NPPV is useful. First of all, OSA. OSA, right? OSA, the gold standard treatment is CPAP, where this continuous positive airway pressure tends to open up the airway, set a higher baseline, so avoid the negative pressure and sucking of the soft tissues causing obstruction. Best evidence, OSA. Second, in obesity hyperventilation syndrome, that's called Pickwick syndrome. We have discussed more in the OSA chapter. But in OHS, there can be two types of OHS. One is OHS with OSA, which is the case in 90% of the cases, where again first line is CPAP only. Then if CPAP is not working, then you can move to BPAP, no problem. In a pure obesity hypoventilation syndrome only, obviously you have to use BPAP only. So whenever you call the word hypoventilation, you have to go for BPAP. Number 3. In a patient who is having a neuromuscular weakness and a neuromuscular disease like probably a long-standing amyotrophic lateral sclerosis, poliomyelitis patient. So definitely BPAP is very, very helpful. In a neuromuscular weakness, the problem is the low tidal volume and the ventilation can be provided only by BPAP. Here you cannot use the CPAP here. Fine. So this is the indications of NPPV for chronic states. What are the contraindications for non-invasive positive pressure ventilation? There are absolute contraindications. The only absolute contraindication as far as I know is cardiac arrest. Definitely you cannot use cardiac arrest. Probably you can tell other absolute contraindications, which is not important. Obviously you should know that. Coma. In patients who are having very, very low GCS or severe encephalopathy. These are absolute contraindications. Severe encephalopathy, coma, very low GCS, you cannot use. Which means if they cannot have airway protection, giving a positive pressure ventilation may cause gastric insufflation and more risk of aspiration will be there. So don't use. But one exception is there, where you can use even in encephalopathy, that is CO2 narcosis. In CO2 narcosis patients, yes, even in encephalopathy, but you should not have low GCS. If the patient is altered sensorium, still you can use a little bit. Then Obviously, if you have a facial trauma, these are no-brainers. If you have a facial trauma and you don't know which is face and which is mouth and which is tongue, you can't use facial trauma and facial deformity. And there are a lot of relative contraindications. One of the first relative contraindications is hemodynamic instability. I told you this already. We don't use it. And if the patient is uncooperative, obviously, these are no-brainers. The patient cannot clear secretions. Obviously, if you want to clear the secretions, go for invasiveness. So that's right, either tracheostomy or a endotracheal intubation, which provides a better pulmonary toileting. So cannot clear secretions. The patient is having continuous vomiting. Clear? You cannot use the mask again. They can aspirate the vomitus. So cannot use vomiting. In vomiting. If the patient is having a recent UGI or a upper airway surgery, if the patient is having a recent GI, gastrointestinal or a upper airway surgery, or the patient is having upper airway obstruction. Obviously, in upper airway obstruction, how can you provide the positive pressure? Not possible. Upper airway obstruction. Other contraindications, UGI bleed, it is similar to that of vomiting only, so there is no doubt. And status epilepticus. How can you use this in a patient who is violently throwing seizures? They cannot hold the mask at all. So these are some of the relative contraindications. But let me tell you the most important, that is the points for exams: cardiac arrest, coma and low GCS, definitely you should not use. Hemodynamic instability, relative contraindication, severe encephalopathy, relative contraindication, and probably, like vomiting and UGI bleed. So these are, whatever I underlined in pink are the most important for exams. So this is what you will be tested. These are the practical things also. Facial trauma, vomiting, and all, it's very logical. You cannot put a closed mask when a patient is actively vomiting or having a facial trauma where you cannot fit the mask at all. That's logical. But these are things you will forget in exam. Cardiac arrest, low GCS and coma, severe encephalopathy except for CO2 narcosis, and hemodynamic instability. 4 standard contraindications, you have to know about this. So we have discussed on a lot of stuff on this NPPV. Let us only see the interfaces, what you're going to use. These are the masks that you're going to use. That's what I'm going to call as interfaces. This is a very practical diagram. So what are the masks we are going to use? The first mask is the nasal mask. So this is the nasal mask that we are trying to use. So this is how a nasal mask will look like. So this is a nasal interface. So it covers only the nose, and you can see the mouth is actually clear. But what are the problems with the nasal mask? The patient should be extremely aware of one fact, that the patient should close their mouth. That's very important. If the patient opens their mouth, whatever positive pressure you are giving to the respiratory tract will leak out through the mouth. So patient should have a closed mouth always. So this is the idea of a nasal mask. Clear? And you have a oronasal mask. This is the commonest type of mask that you're going to use. Oronasal mask. This is the commonest type of mask that you're going to use. Remember, tight fitting of the mask is really important. Otherwise, you will result in leakage of the positive pressure. So the whole purpose of the NIV itself will be going waste. So you have to have a tight fitting. So you can see this is how a oronasal mask will look like, where it will cover the nose as well as the mouth. And whenever you use a nasal mask or a oronasal mask, so this problem is very common. Abrasion and injury, skin irritation is very, very common in the nasal bridge. So you have to anticipate that, and slightly you might reduce the cuff pressure that you are using to elevate the silicone. But apart from that, you can't do anything. So more and more loosening the mask will result in leakage of positive pressure also. This is one problem with this oronasal and nasal masks. And these are the full face masks. Full face masks. This is a different interface where you can see the patient's face is covered in full. Entire face is covered. This is a full face mask. This is advantageous in one way, in the fact that some patients feel better and they don't have this nasal irritation. But this is causing more claustrophobia. Compared to the oronasal and nasal mask, this is going to cause a significantly larger amount of claustrophobia. But apart from that, this is a little more comfortable in patients who don't want this abrasion over the nose. This is a full face mask. Then this is traditional. Patients who are wanted NPPV in home, so they can prefer this. This is a helmet type of mask. where the patient can wear like a helmet. Extremely claustrophobic again. But if the patient is suffering from severe claustrophobia, don't use this kind of mask and all. But this is very good home option. Nowadays, it's not available in most of the scenarios. Now we have this nasal pillows also. We have seen this in oxygen delivery device itself, where I discussed about something called a NIOV. That's a non-invasive open ventilator technique for delivering oxygen, pulses to conserve oxygen. So there I would use this nasal pillows. This is produced by ResMed, and the patients who are again having a claustrophobia, this is one of the best. So they will be again having a nasal pillow that is tightly fitting into the nose only, like this. They don't even cover the nose. And this will avoid nasal abrasions. This will not have claustrophobia. And only one thing, here also the patient should avoid opening the mouth, because otherwise the positive pressure will leak. So you have to close the mouth and only be there in the ICU for a longer time. So otherwise, like the pressure will leak from the mouth. So this is something, like dramatic. This is a oral mouthpiece. Oral mouthpiece only, where you can provide positive pressure ventilation just through the mouth. So this is also referred to as a mouthpiece ventilation. Clear? So you might ask me, sir, whether the positive pressure will leak or not. Yes, definitely will leak here because the nose is open only. But that's why we are using one important principle behind this. That is, this will be used only for patients who are having chronic neuromuscular weakness. You can see the image and tell that this patient is definitely in the wheelchair, which means he is having some chronic neuromuscular weakness. In this patient, the patient is suffering from ALS, amyotrophic lateral sclerosis, where the most common cause of death in ALS patients is respiratory failure because of the neuromuscular weakness. So the problem in these patients is they cannot distend their alveoli. Alveoli may be a little collapsed, but not the major issue in these patients. Here the major issue is the patient cannot distend their alveoli because of the neuromuscular weakness. So here the IPAP becomes the most important, because you have to distend the alveoli and provide ventilation for these patients. Here the most important is the ventilation for the patients. So that is why IPAP becomes quintessentially important in these patients. So you give an inspiratory positive pressure, that's enough. Ideally, you don't need the EPAP at all. In a pure patient with only neuromuscular weakness, where the respiratory drive is all right, you don't need a EPAP at all. So that is why this is the basic principle of using a mouthpiece ventilation, where you can set EPAP of 0. Why? Because you don't need an EPAP. You don't need a P because you are not trying to open up the alveoli. You are only trying to distend the alveoli here. So again, you can set a IPAP of somewhere around 15 to 20 centimeters of water, which means you are having a larger difference between EPAP and IPAP, which means your ventilation will increase. You can distend the alveoli to a great extent during inspiration. So this machine, once they place it in the mouth, this machine will trigger their inspiratory effort. The moment they have that small pressure drop during inspiration, that will trigger the machine and they will produce a positive pressure in the form of inspiratory positive area pressure, and they will distend the alveoli and they will come back to the normal position. So they don't provide any EPAP support, but they still do provide IPAP support. That is the basis of using just a mouthpiece ventilation, and this is a boon for many ALS and polio patients who are at end-stage disease, because this will definitely help them big time, and this will avoid the invasiveness also to a great extent. Clear? And this will not having claustrophobia, the nasal bridge, covering the face, all these things are not needed. Excellent one for these patients. And you can set a backup respirator if you want, but generally not needed. Plus or minus, you need, if you want, you need a backup respirator, you can set that also. But the most important here is to set a proper IPAP. That's what is the key here. So these are the different interfaces that you have to know, which I have shown you images and examples for each and everything, where you have a nasal mask, you have a oronasal mask, you have a full face mask, helmet mask, nasal pillows, and mouthpiece ventilation. Clear? So with this, we can close down our NIV discussion. NPPV, I think this NPPV topic would have made a lot of sense now, because it's quite easy, and the indications are the most important in this entire topic, and the masks, they could come in the exam as image-based discussion. So be careful about all these things. And with this, we can close down the session. We can move to the next section from now on.